I want to say hello and welcome to another featured grand rounds here at MEDACTA. My name is Max Krupp, Senior Product Manager for knees, and I'll be moderating the event tonight. In today's grand rounds, we're focusing on one of the fastest growing trends in total knee replacement, which is the Caliper verified kinematic alignment technique. And we're really thrilled to host this exciting session with two industry-leading surgeons, Dr. Stephen Howell and Dr. Keith Barron this evening. They bring decades of experience from their backgrounds, and they're going to be diving deep into the concepts of kinematic alignment, as well as review some cases and touch on implant design and the concept of the athletic knee. And then we'll finish up with a Q&A session at the end. I'd like to just take a quick moment to introduce our presenters this evening. We're very fortunate to have them both with us. First, I'd like to talk about Dr. Keith Barron. Most of you are very familiar with Dr. Barron and his work over the past 20 years. He's achieved many accolades and recognition in both hip and knee arthroplasty. A very prominent member of both the Knee and Hip Society. We're very fortunate to have him with us tonight. He recently, in the past year or so, started doing kinematic alignment, and he's going to be giving us some insight on what he's seen so far. We also have Dr. Stephen Howell practicing out of Lodi in Sacramento in California, and he also has a wealth of experience over 3 decades in knee replacement, ACL, sports medicine, and meniscal surgery. Dr. Howell developed the Caliper verified kinematic alignment method back in 2005, and since then, the trend has just grown dramatically over the past few years. To date, he's probably done about 6,000 of these knees, so I'd say a lot of insight to be had there. So again, we're very fortunate to have both of these gentlemen on this evening. I want to thank you both for being here with us tonight. And with that, my time is finished. I'd like to now kick it over to Dr. Barron to go ahead and get rolling. Dr. Barron, if you please.
Great. Thanks, Max, and thanks everyone for being here and taking some time. I want to talk about, just as a background, I'm going to primarily focus on the varus knee, but really what I want to do is take the opportunity to kind of talk about how I ended up on a MEDACTA grand rounds, talking about a specific implant that I've been using, the Sphere GMK primary total knee, and most importantly, the technique that I've been using about the last year, as was said. So 20 years of practice, 1 year of experience with this technique. As many of you know, we at JS Orthopedics keep a database that goes back to the days of Dr. Mallory, and I'm going to present some of our early data using this strategy, and hopefully open that up for some discussion. And then I'm really looking forward to hearing from Dr. Howell, as I have the last year, some more tips and tricks about this technique. And so the first thing is kind of thinking about a knee like this. So for 20 years of practice, I would see bilateral bad varus knees, fixed deformity somewhat, flexion contracture. I'm always thinking partial knee replacement, but when I'm not and it's time for a total knee replacement, I would traditionally, for the last 20 years or so, have done an instrumented mechanical alignment type technique and then some type of soft tissue balancing around that implant. I've migrated over a 20-year career from strictly a pure cruciate retaining type design to a ultra congruent design that I've used for the last 10 years plus in almost all of the knees that I do, with the goal of a straight knee, of mechanical alignment, a 90-degree cut on the tibia, 4 or 5-degree valgus cut on the femur, and what we would traditionally call a straight knee. As I've started exploring this kinematic alignment concept, I started to think back, and it struck me that this wasn't actually a really new foray into this space for me. These are images from a case that I did April 19th of 2006, so 2006. And if you look at the initials down here, there's 3 sets of initials. There's CC, there's SH, which is Stephen Howell, and there's KB, which is Keith Barron. And this was a case that I did early on when Dr. Howell and others were looking at using a technique to recreate the actual spherical or rotational axis of the knee that was shown in this article. And you can see medially and laterally, there's really a spherical axis to the knee. And the concept that Dr. Howell was trying to espouse was we could use these custom cutting guides and we could use pre-op planning, and we could recreate this, this spherical axis. And this was what was kinematic alignment, and it was attempting to do kinematic alignment with a custom cutting guide or with a a patient-specific type cutting guide. And Dr. Lombardi and I kind of latched onto that. We got pretty heavily into custom cutting guides, but what we could never really kind of get rid of or rid ourselves of was this concept that we wanted the appropriate alignment. We wanted to straighten the leg with the bone cuts, and then we wanted to balance the flexion and extension gaps using soft tissue balancing. And so in this illustration, you would see we'd cut the tibia at 90, cut the femur at 4 or 5, and then do the same thing in flexion, cutting what we would call the appropriate rotation or the transepicondylar axis or whatever other axis you wanted. And then we would release the soft tissues to make the rectangle in flexion and extension. And we did this with manual instruments. We did it with custom cutting guides. And in fact, we were kind of so proud of ourselves that we published this series in 2015, where we proved that using custom cutting guides, we could hit that central weight-bearing axis or make the knee straight nearly every time. And that was kind of the concept that we've used, and we've used for 20 years. And as I've gotten into kinematic alignment, I sort of thought back to the time when Dr. Howell and I he was trying to explain to me what kinematic alignment was, and I was still trying to make the legs straight, and we were publishing that the legs were straight. And some 15, 18 years later now, I've come back to this other concept. And the way I came to sort of start thinking about it was I wanted to start looking at this concept of the medial sphere knee, or the medial pivot knee. And here's a couple of studies, 3 in particular, that show that the medial sphere knee has a better kinematic profile than ultracongruent, which is what I was using. I also had found that after literally 20 years of practice of mechanical alignment and mostly ultracongruent knees, I had a reasonable patient satisfaction, like I think all of us do. But I had a pretty high manipulation rate, and that's not a benign procedure, as many of you will know. And so I started thinking about, well, maybe this medial pivot or this sphere concept made sense, whether it's kinematically, as you see on the 2 images on your left-hand side of the screen, or whether it's gait analysis from University of Ottawa on the right-hand side of the screen. It looked like the concept of the medial pivot made a ton of sense. The other thing that we started to notice was this idea of kinematic alignment further made sense, or further showed that you could improve the normal kinematics of the knee, not only through this alignment principle of kinematic alignment, but coupling that with a specific implant design, in this case, the sphere or the medial pivot type knee. And so that's why I started thinking about it, and I started thinking differently about my knee replacements. And so this is a case of mine within the last year or so. And you can see that this is the same case, bad varus, fixed deformity. And instead of aiming to get the tibia cut at 90 and make a rectangle by releasing, in this case, I would have released the MCL in every case, the knee's going to end up looking like this, where one's a little bit more crooked still than the other. They're back to their straight, they're perfectly balanced. And it seemed like the patients were doing pretty well when I really switched over wholeheartedly to this kinematic alignment concept with calipered confirming. And so the definition, and this is a slide that was taken from Dr. Howell. This is when I went back and said, well, I'm going to go ahead and start doing this. I reached out to Dr. Howell and I said, send me some info, remind me what it is that you've been doing. And this is what he said. Basically, you want to take all 3 of the axes of the knee, medial, lateral, and patellofemoral, and think about them as a pivot point, or think about them as a sphere. And if you can co-align each one of those axes within the joint line, you've got a kinematic alignment. I've heard, since I started doing this, loads of surgeons, prominent surgeons, say, well, I've been doing kinematic alignment forever. I cut the tibia in gentleman's varus and I rotate the knee a little bit, and then I put it in, and that's kinematic alignment. Well, it's really not, particularly when you think about the femoral rotation. And what really struck me as being normal about this operation is we, through calipered alignment, through caliper checks, we are cutting off the same amount of bone and cartilage that we're replacing with metal and plastic. With any other technique that you use, you're not doing that. And so you're by definition either raising the joint line, overstuffing the joint, or having to release ligaments. And when I went to this about a year ago, I said, I don't want to have to release any ligaments. I want the leg to be straight. I want it to be the pre-disease alignment. Most of these folks that have varus knees have constitutional varus. They should be in a little bit of varus. They certainly shouldn't be any valgus. And when we finished up with our mechanical alignment, as I showed you in that study, the knees were straight. So they were in a relative amount of valgus, which is an overcorrection for most varus knees. And so here are those axes. So here's the lateral and medial axis of the knee. And then the yellow line is the medial pivot axis of the knee. And where those coincide, you can see you've got three distinct axes. And the only way to really reconstruct that is with geometry of the distal femur and of the tibia that's different. You can't have an ultra-congruent bearing on the medial and lateral side and expect to reconstruct these three axes. You have to have a ball and socket or a sphere on the medial side, and as you can see here, a relatively flat or even convex surface on the lateral side. And that's what's done with this device using this technique. And here's how the caliper basically works. You want to reconstruct these axes, and so you make a series of bone cuts. You still use mechanical instruments for this. You can do it with a robot. You can do it with patient-specific guides or custom cutting guides. But in this case, we're using manual instruments. They do make a set of disposable instruments or single use that are actually really nice, particularly in the outpatient setting. But we're going to cut the distal femur aligned with the patient's normal alignment. We're going to measure that femoral cartilage and bone or loss of cartilage and bone, and we're going to reconstruct it exactly as we would with putting in the implant with the metal on the femur, the same thickness of the posterior cut and of the distal cut in all planes. And so you also, in doing this mechanically, and we'll show some videos, you basically use the instruments to make, and the kerf of the saw blade to make up for the cartilage that's been lost with whether it's a varus or a valgus knee, and whether it's super severe and goes on to the posterior condyles of either the medial or the lateral femur, which usually it does not, but sometimes it does. So here's, again, verification with the caliper. It's incredibly accurate. I think it's probably, as does, I'm certain, Dr. Howe, more accurate than the robot. And the reason I say that is you're measuring it with a caliper. And if you're off by a millimeter, you fix it, either one way or the other. Folks ask me all the time, well, what do you do if you take too much, you can't put it back? Well, you make up for that on the tibial side, and we'll show you how that's done. So here's basically, these are just videos showing. This is one of the things that I really like. We put this into our medical record now. And particularly, it's interesting when you do bilaterals down the road to go back and look and see what you did on one knee. You almost always do the same thing on the next knee. You record your femoral resections, you record your tibial resections, you record your alignment, and all of these thicknesses, and it just comes out with a really balanced, really straight knee. But you got to believe the calipers, you got to believe the balancing, and you got to believe in the fact that you don't have to release the ligaments in order to get the leg straight. And so here's the distal femur. You're measuring with the caliper. You'll record it both medially and laterally. You can see here in this example, this is a varus knee. And so you've got 8 millimeters of distal femoral cartilage and bone, plus the saw is 9, same thickness of the distal femur. And then on the medial side, it's 6, but you've used a shim on the distal femoral alignment guide to make up for that loss of cartilage. And so by taking off the exact same amount you're going to replace with the metal, you truly have kinematically aligned the knee. And then most importantly is the flexion, where you take out the flexion, the posterior condyles, and measure those. Routinely, they're going to be unworn, and so they should be 7 and 7. So you've got 7 millimeters of bone and cartilage, 1 millimeter of saw, and you replace it with 8 millimeters of metal. And it's really remarkable how simple it works and how easily it works, as you see here. Here's me doing the same thing. Again, distal femur, 8 millimeters plus 1 is 9. 6 millimeters with 2 millimeters of wear plus 1 is 9. I measure that I'll make any minor adjustments that need to be made so that we're right on target on every knee, and then proceed on with the next steps. One thing that I do, I mentioned this, you want to have equal and lateral, medial and lateral resection. So medially and laterally, you want to measure it and you want it to be equal. Almost always, especially if you've been a mechanical alignment person in a varus knee, you'll have to recut because we're just not accustomed to cutting that much varus in the tibia. But if you, for example, over resect the posterior condyles, you can take a little slope out of the tibia to make that flexion gap equal and to make that kinematic alignment effective. Same thing with if you under resect the posterior condyles of the femur, you can take a little bit more slope. You can add a little bit more slope if the flexion gap's tighter than the extension gap, et cetera. So there are some fine tuning that you can do. Most of it's instrumented, which I really like. Again, in a varus knee, frequently you won't cut enough varus in the tibia to get it balanced the first shot, and you end up taking a little bit more varus tibia. So here's where you're checking an extension and inflection, and you can see that it's perfectly balanced. Then it's perfectly balanced with the implant and the trowel in place, and the leg's straight. This is a varus knee. You can see the tibia is in varus. I mean, it's clearly, you don't see much of it, but what you do see, it's in varus and the femur's in valgus, but the leg ends up straight because of that. And most importantly, it ends up balanced because of that. And then the real question is that, does that make a difference? Here's another knee, a little bit worse varus. You can see, I don't know, I'd guess 6 or 7 degrees of varus on the tibia. And then the same, 5, 6, 7 degrees of valgus on the femur. Perfectly balanced because it's also perfectly balanced in flexion with those resections. Here's another one, pretty bad varus. Here's the post-op film. Again, a lot of us, me in particular, a couple of years ago, I would be really concerned with this. This has not been a concern out to a year in terms of any tibial loosening or tibial sided failure or instability. But most importantly, Dr. Howell's got experience for 20 years of doing it this way, or 15 or 18 years. And again, with multiple different implant designs, no issues with increased tibial loosening. So I don't have the long-term data. What I do have is short-term data. And this is what has been really compelling to me. You guys and gals have heard at all the different meetings, anecdotally, my patients are doing great. My therapist came up to me and said, "Hey, what are you doing different?" Well, my therapist came up to me and said, "Hey, what are you doing different?" And so we looked at the actual data. This is my first 97 patients, 107 total knees, first 100 basically kinematically aligned sphere medial congruent total knees, compared with the last 200 mechanically aligned ultra congruent total knees that I did. So 200 patients, 223 knees. These are literally the first 100 of the KA medial sphere and the last 200 of the MA ultra congruent. So this is 20 years of practice doing quite a few knees, hoping that I'm decent at it, mechanical alignment, versus completely throwing caution to the wind and believing in the concept and doing 107 knees, recutting in varus if it needs to be, recutting in valgus if it needs to be. And you can see the BMI, actually, they started a little heavier. The pre-op range of motion was a little worse, and that was statistically significant. The post-op range of motion at 6 weeks, so this isn't 2-year data, this is 6-week data, was statistically significantly better. And most importantly, the delta was on average +5 versus -2 in my traditional knees. So really statistically significant. You can say, well, it's not minimal, whatever, but that's great. But on average, they were statistically significantly better at 6 weeks. And then look at the medial soft tissue releases. Of any type of release on the medial side, 26% of the time, over a quarter of the time, I was releasing the MCL with my mechanically aligned knees, and that's dropped to less than 3%. And interestingly, those 3%, those 3 knees were all within the first 20 or 30 knees that I did. In the last 100 that I've done, I've not done any releases of any kind. And then look at the manipulation rate. So we manip our knees for poor range of motion at 6 to 8 weeks. Steve, Dr. Howell, has sent me nice messages over the last 15 to 20 years whenever I publish that, and said, "Man, you need to figure out what you're doing. You're doing it wrong." And I didn't believe him, but this is my data. The manipulation rate in the last 200 knees that I did with mechanical alignment was 11%. More than 1 out of 10 knees came back to the OR for poor range of motion after 20 years of experience with total knee replacements. In the first 107 KA sphere knees, it was less than 3%. It was actually 3 out of 107. Again, those 3 were all within the first 30 knees. In the last 100 knees, I've manipulated 1 patient. There is something substantial. There is something different. The early recovery is different. The knees behave differently. I believe it. I think this data clearly shows that there's something to it. In my own hands, I'm going to wait and watch and continue to do it this way and make sure that there's no problems with early or midterm mechanical problems. Thus far, there's not. I believe Dr. Howell and some of his disciples, as it were, some of our previous fellows, Ryan Molly, Craig Lux, have been doing this for a long time. I've seen a lot of their x-rays. Really, there's something to this, and I've been super impressed. Lastly, and probably as notable as this data is to me, is a knee like, well, I'm sorry. So there's other people that have seen this data as well. This was actually just published in August. This is one of those little cartoons that the JOA puts out. And this was mechanically aligned versus kinematically aligned knees. The KA results at 6 weeks were better, but also better at 1 year and 2 years, and had higher forgotten joint scores at 1 and 2 years. So I'm seeing this result early at 6 weeks and then up to a year. This data really compelling. JOA published last month. It makes a huge difference. It makes a difference in the KOOS. It makes a difference in the forgotten joint scores, which are probably the things that matter the most, right? It doesn't matter if we think they've got a great score. It's what the patients think, and they think on their KOOS junior and they think on their forgotten joint score. And then finally, I used to go to the OR with knees like this and think, geez, this is going to be a tough knee. This is going to be hard. I got to think about how to cut this. I got to have constraint as a backup if I have to over-release the MCL and all of a sudden it gets loose. This was a tough knee for me, even 20 years of practice. This is now an easy knee, and it's actually truly easier than some of the easy knees. And I say that, to me right now, using this technique, the tougher knees are the patellofemoral, where the tibiofemoral joint's relatively normal, to figure out how to really line those up using KA, because it's so straightforward and so easy. It seems like you're not doing it right. But on a tough knee like this would be a tough knee. It has turned into a really easy knee because you don't do anything to the MCL. You don't have to release it, lengthen it, balance it, pie crust it, play with it. You just cut the knee and you cut bone until the knee's stable. And then you get an x-ray that looks like this, where the knee's pretty darn straight. And the early results in our hands are really good. And so taking a tough knee and making it easy with a pretty simple philosophy of cut what you're going to put back with metal and plastic and keep cutting until you get it straight. It's made a huge difference in my practice early on. And admitting that I've, in 2006, argued with Dr. Howell that knees needed to be straight, and we were going to use this patient-specific alignment to make them straight, and being proud that we made them straight, but that our manipulation rate was high. Admitting defeat and now championing this concept, I think is there's definitely something to it. So I think appropriate alignment is a valgus femur and a varus tibia when it comes to a varus knee. The leg will end up straight, as I'm showing you here. With no releases, you get excellent balance, particularly around this medial sphere type design where the lateral side is free to do what it needs to do. There's way less, if not zero, soft tissue releases, way less, if not zero, manipulation, and an early increased range of motion that's noticeable to the patients and to my physical therapists. And so that's been my early journey back into this world. And I'd love to hear what Dr. Howell has to say about the valgus knee, perhaps. Give us some insight into that, and then maybe we can come back around and talk about where this all started and where we are now. So thank you for your time.
Well, thank you very much, Keith. Can you hear me, Keith? Can you wave? That way I know everybody else can. Yeah, good. So we've got the workings of this software going. And I want to thank Dr. Barron for his kind words and for his foray, if you will, into KA. I visited him in April. I had been dying to go out there for years. I've known Dr. Lombardi. He and I were in Philadelphia together at the same time, and I've always admired what both of them have done in the joint arthroplasty world. And I wanted to see how their surgery center works. And I came back and instituted immediate changes in our OR with the efficiencies that they have. And my OR is now working better. And now I'm really proud if someone wants to visit me to tell them that I'm using the joint implant surgeon's approach to how to get the instruments out, keep your trays small, get the turnover high. But as Keith said, the real thing with KA is becomes sort of like a uni in terms of recovery. And that changes your whole office hours. You end up seeing patients less. They'll come in and sign up for their other knee in a hurry. And so you're in the OR more, you're out of the office more, and your patients tend to be happier. About 1/3 of the patients that we do, probably 27% in that range, are valgus knees, as you see here in this particular case. The principles are essentially the same for the varus, valgus knee, and patellofemoral. You take off what you put back and let the components do the job. So let's see if I can move this forward. There we go. So this is what that lady's knee looked like. And she was 50 years old. People are telling me the MCLs contract, but most of the time these x-rays are taken with a little bit of flexion, even though you're trying to get the knee fully straight, or the x-ray technologist is trying to get the knee straight. They got a little flexion contracture. Their posterior lateral capsule is tight, and that forces that lateral femoral condyle to sit in the posterior half of the lateral tibia in the defect. And that makes the deformity look worse than it actually is. Once you get that knee straight, which you usually, and I'll show you the little trick about the posterior lateral capsule, once you pop that, the knee comes over out of valgus, and that's something you have to remember. So this knee, the MCL is not stretched. And as I'll show you, this concept that we've heard that the lateral femoral condyle is smaller than the medial one is just, how should we say, just not true. And that then enables the mechanical alignment person to cut less off laterally than they should, and that tightens the lateral side and leads to all the releases, which we don't have. So with KA, and it was interesting when Dr. Barron mentioned Dr. Moley and Dr. Laux, because Dr. Moley, when he started doing KA maybe 5 or 6 years ago, he said to me, he said, I don't need constrained implants anymore to do the valgus knee. I just use primary implants, and that's what you find that you can do. So if you look at this concept of hypoplasia, you can analyze it measuring the radii of the medial and lateral femoral condyles and look if there's a difference between the varus and valgus knee. And we published this paper in 2010. And this is an example of a typical valgus knee. There's the medial pose of the MRI, and there's the lateral pose. And you can see all that joint fluid and the loss of cartilage. But if you best fit a circle to the posterior condyle from, say, 15 of flexion to 120 and pass it over to the medial side, it's the same. So the radii, or the circumference of the medial femoral condyle, is the same in the varus valgus knee. It's just the cartilage is worn. So if you are planning to do a KA knee with a 9 millimeter thick distal femoral component, you're going to make an 8 millimeter bone resection plus a millimeter of the kerf to get you 9, and you'll take 6 plus the kerf to get you the plus 2 for the cartilage and for the kerf to get you 9 distally. And as Keith said, that really bad varus knee he showed, what's surprising is you can almost take it to the bank. There's very, very little risk of bone wear at 0 and 90, even in the most arthritic knee. And why is that? Because when you have a badly deformed knee, they can't straighten it. So for the last 10 years, they're walking at 15 degrees of flexion. When you put your referencing guides down in the distal femur, they're at the 0 point on the bone. It's not worn. And the posterior bone at 90 degrees doesn't work. There's no load on it hardly. So you can usually, even the most severe knee, at 0 and 90, when you reference with the manual instruments, you can bring that joint back pretty close to where it was. So if you look at the bone resections here, we took 8 millimeters distal medial and 6 distal lateral. And then we had 7 posterior because the implant is 8 millimeters thick posterior and 9 millimeters thick distally. And that's what the tibial resection looked like. Very little bone removed from the posterior lateral corner, because that's where the erosion takes place. So you look at these people come in over time, and they come in 25-degree fixed valgus deformity. You scratch your head, I can't do this. Really, it's just sitting in this hole. So once you fill that back in, for every millimeter that you shim open a tight joint line, you move the ankle 6 millimeters over. So assume that you're missing 2 millimeters of cartilage off the femur, 2 millimeters of cartilage off the tibia laterally, that's 4. Say you got 3 millimeters of bone wear, that's 7. So 7 times 6 is 42 millimeters. So you can tell your patient that when I'm done, Mary, your ankle here is going to move over about 42 millimeters, and that will take out of the deformity, it will take the valgus away and take them back to where they were when they were, say, 20 years old. So this is an example of this patient right now has had all the cuts made. And it's tight lateral, and you say, but you go back and you take, just as Dr. Barron showed, you take that tibial piece, and I'm going to lift my phone up. If you consider this to be, if I can get it, a tibial resection, you're going to measure at the base of the spines. And the better you get at it, you get pretty good. And so let's say that you make that bone resection, you measure, and you say, I take 9 millimeters off both sides where there's no cartilage wear. That's a good cut. Yet you're tight posterior lateral, and you shouldn't be because you did your distal cuts right. Then put your trial components in and do this move. So that stretched the posterior lateral capsule. When that happens, then the lateral side loosens, and it allows the tibia to come over, and you have a straight knee. So that is the little trick on the valgus knee, is do everything you do on the varus, only reverse it, for the cartilage wear. But if you get in with your spacer block and extension that's tight lateral, stop, get the tibial piece out, measure. I think I have a pretty good cut. Resist the temptation from recutting the tibia at that point. Then put your trials in, give it a push, and you'll find that most often than not, you restore that alignment. So this is what it looks like afterwards. And this is just a short pose of the knee. If we then take a long leg scanogram, you can see that the distal lateral or femoral mechanical axis or distal lateral femoral angle or proximal tibial angle on both sides are the same. So our target is to match the other side. So my suggestion is, in the recovery room, of course, if you want to get an x-ray and just get a single view of the knee, that's fine. But when they come back to your office at 6 weeks, get a standing x-ray of both knees. If you don't have the long leg, you only need the knee, and just measure the distal lateral femoral angle, proximal tibial angle. It should be the same as the other side. I mean, that's what we do. So our target is to restore the patient's prearthritic joint lines. So from the definition point of view, kinematic alignment puts no tibia cuts in varus or valgus to the kinematic alignment target. If you look at mechanical alignment with a kinematic alignment point of view, you'd say, well, you're cutting all your femurs in varus, and you're wondering why you get varus tibial loosening. And when you do MA, you're cutting all your tibias and valgus, but not as often as you're cutting, or not as much as you're cutting the femur into varus. So you have a higher risk of a varus deformity after MA than you do a KA, and you get medial overload when that happens. And so that's why it's the scourge of mechanical alignment, varus tibial loosening or tibial polywear. We don't see it with KA. And there's going to be a paper coming out within the next month from KSSTA with 1 year RSA measurements of the migration of the tibial base plate with kinematic alignment. And we now have another study that's nearly complete with both 2 types of very stable medial inserts, the ball and socket sphere, and one a little less intermediate, no migration, just negligible. So you can take it to the bank that if you want to solve the varus tibial component loosening problem, stop doing MA, don't do functional alignment, don't do restricted KA, just put the joint back where it was. So you can see that we restored the distal lateral femoral angle, proximal tibial angle within a couple degrees. There is some side-to-side variability. We learned that from a paper by Eckhoff, and we have a phenotype paper a few years ago that looked at the side-to-side. It's pretty close, but not perfect. So if you're not quite equal to the other side, but within a degree or two, you're probably just fine. And then the other thing we want to do is try to restore the slope. So what happens now, as Dr. Barron was mentioning, we now have an ACL intact knee when we do total knee replacement with a medial pivot, ball and socket insert, and femoral component. They got an ACL. And one of the things that always perplexed me, and also the patient, is you have this 60-year-old patient wants to be a 50-year-old, and the 70-year-old wants to be a 60-year-old, and they come in, doc, my knee's been bothering me. Well, what's going on? Well, I walk with my wife, and I go mile, and if I go 2 miles, my knee gets sore, and if I'm on uneven ground, it aches. And it aches, and I'm always pointing anteriorly on the medial side. And then my answer to them is, well, you should be thankful. I gave you a knee to go walk a mile on. I don't know what you're complaining about. You can go see another surgeon. They're going to tell you the same thing. But now I'm starting to think, well, what's going on with these people is they get exercise-induced intolerance to the joint. And that's what lowers the forgotten joint score. They get this micromotion. It's not the same as instability, but it's just this back and forth shucking, enough to make the soft tissues having to come into play when they're on uneven ground going up and down hills. So I think the combination of KA with the medial ball and socket concept can give us the possibility of getting more athletic-like function, which enables us to treat these poor, desperate 50 and 60-year-olds with monoarticular OA from an old ACL injury and reconstruction or sports injury or meniscectomy, and they want to stay fit. Can we deliver that? I believe that's the new frontier, and I believe this combination has the chance. So let's see if we can take a look at this video. So in the normal knee, the medial meniscus is firmly attached to the tibia with a coronary ligament and behaves like a socket. And so if you have a sphere, as you see, this is the medial view there, we have a nice socket. There's none of this oscillation or micromotion. If we take the typical knees that I've used over the years, they have a less conforming or low conforming medial insert, and you can see the little bit of play. And that is what I think gives this activity-induced intolerance to knee function that we can maybe solve with the medial pivot knee. This is the lateral side. You can see the fibula. And for those of you that have studied the sports world, the lateral meniscus is load-bearing but not stabilizing. It doesn't restrict AP movement because it's so mobile, there's no coronary ligament. So essentially in deep flexion, whatever, the lateral plateau with the meniscus there in the normal knee is flat for all sense of purposes. So that leads us to the concept that maybe we'd like to have a flatter lateral side to allow the tibia to internally rotate properly, which is needed for the patella to adjust its IE position as you flex the knee to reduce the tension on the retinacular ligaments and perhaps reduce the anterior knee pain. So if you look at the free movement on the lateral side and compare that to a conforming one, the conforming one, it blocks external rotation and extension and internal orientation and flexion, which leads to a relatively stiff knee. So I think what we can do is stop here. We have at least 17 minutes, if not more, and we can start answering some questions. So Keith, maybe you have some comments from what we have to say. And
yeah, I think, Steve, it's great. I mean, I really don't have a significant dog in the fight other than going down this pathway by wanting to pursue some of the kinematics that you just showed at the end, and realizing that when using that concept with the medial sphere, it makes the most sense to not try to balance the knee ligamentously around the pivot, right? So if you have this medial sphere concept, put the center of the ball into the middle of the sphere where it belongs, instead of resurfacing the end of the bone with a ball, the top of the tibia with a sphere, and then balance it because you've put it somewhere where it doesn't belong. And I think that is the basic premise of what you showed at the end with, as you call it, the athletic knee. You know, Mario's data out of Ontario showed a very similar finding in that, you know, a lot of our knees will do great, literally great, on level ground. But if you start to try to go downhill, and especially go downhill fast with a total knee replacement, that's where the performance starts to lack. And, oh, well, then don't go downhill fast. Well, that's fine if you're, you know, the 80-year-old grandma who lives in a one level. But when you're talking about doing total knees on 50-year-olds, you know, they want to go back to high activity level. And I think we're in an era with the materials that we have and the polyethylene and the fixation that we don't have to restrict people from that standpoint. And unfortunately, our implants are restricting them by their performance. And I think this is a real game changer. I mean, I think, as I showed, my early data is super duper encouraging. But I think more importantly is the data that you've accumulated and others, and the lab data, both in simulation and in real world gait lab data like Mario's, that show that there's a real difference here. And it goes back to what you said at the beginning. You know, I've always doubted that these would behave more like a uni, because unis have done so much better than my total knees. We've published on that since I started doing a particular uni in 2004. But these knees do. And it also makes me not want to push the envelope with the uni quite as hard, because you will have some early failures on the lateral side or other complications. I still do a lot of unis, but I'm a lot more comfortable doing a knee in someone and knowing their recovery is going to be a lot easier. And then your data and others telling me that it's going to be fine in the long term. It's really exciting.
Well, Keith, you know, you have a little bit of company across the pond. You know, that particular uni that you used to do, I'm not going to say it was from Oxford, but but Andrew Price and Will Jackson are now doing kinematic alignment with the medial pivot knee, and they just gave a talk there a few days ago, and I got a copy of the slides, and their experience has been exactly like yours, that with the uni, that they are starting to, when they think that there's one where maybe the ACL is not quite right or a little, they'll do the KA knee because their recovery is very similar to the uni. And if you think about a uni, it's also got a little extra play on the medial side, which that's where we have to see if stabilizing that medial side like we do now with an ACL functioning insert. And this was what's very, very important about the RSA data, because when you start to capture the knee, that is the femur and the tibia are captured by the implant, you transmit more force between the tibial base plate and the cemented surface. And for us, we tend to keep to PCL, which if you're a little too tight in flexion would also cause some leverage in the flexion extension plane. And that was why we went through the study first with a CR insert with a little less conforming than a socket. And now we've got 6-month data in a full conforming. It just doesn't move. And one of the things you might think about is, because we got a medial pivot, we're not sliding back on the medial side and sliding forward on the medial side. We're staying in the middle where the stem is and the cruciate is. So I think that all of this plays for an implant that has good longevity, and that the plastic should hopefully do the job.
Hey, real quick, gentlemen, I want to point out that I'm noticing a few guests on the line are raising their hands to ask questions. Again, folks, if you were late to the call, the functionality for attendees limits your ability to use a microphone. So we would ask that you use the chat function, which is at the top of your bar. And if you click on it, you're able to type on a bar on the right side of the screen, which will allow you to submit your questions. So I just wanted to quickly remind everybody of that. Thank you. Sorry to interrupt.
No, Max, that's great. So what I'm going to do is run down a couple of these questions. So one I think is a basic one, and that is, why is the medial stabilized knee the preferred implant of choice for KA? And I think both of us just hit upon that. I think that I came to it kind of through the back pathway of wanting to use a medial stabilized implant, and then figuring out that KA makes the most sense with that implant. Kind of for two reasons. One, I think it is not a great implant for the surgeon that wants to try to ligament balance around it. It doesn't make as much sense to me as an ultra congruent if you're going to do that. And the opposite statement is, if you're going to do KA, you probably should try to not only align it kinematically, but use the device to drive or allow the normal kinematics because of the way you've aligned it. And that's what a medial sphere does, as Steve just said. It captures it medially. It's free to move laterally. Probably why these knees, in my opinion, and in Steve's data, have less anterior knee pain, because they're able to move laterally. I hear people say all the time, well, I use an RP, so it doesn't matter. Well, that's not true. It's been shown that actually, the RP, because the pivot point is in the center, it doesn't function as the way that we think it does for the patellofemoral axis, and the sphere does. So I think the combination is what's really deadly in terms of getting the good results. And then the next question is, are patient-specific implants the next logical improvement? I don't think you need a patient-specific implant. I think that, in fact, and I'd love to hear what Steve says about that, I don't think a custom implant is helpful in this solution. I think customizing the alignment through calipered, confirmed kinematic operation or through some other type of technology, whether that be patient-specific guides, whether that be a robot, doing something to improve your handling of the kinematic concept and using a sphere, I don't think a custom implant helps whatsoever, and probably adds a variable, an unknown variable to the equation. What's your thought on why wouldn't custom implants be perfect for this, Steve?
Well, we've already seen it with conformists. You know, they changed the geometry of the implant so that it doesn't really match the native anatomy. And then they have this custom implant that they then put in crooked to the native knee because they're doing mechanical alignment with that, which then causes ligament issues. So the fundamental groundwork to start to make the knee function right is just resurface the knee. And the only way to accurately do that is to take off what you're putting back and confirm it with a caliper measurement. So if you're a robot enthusiast, navigation, PSI, check your cuts. You know, just because you plan it, and I'm going to tell you, one of the biggest errors in all of those techniques, because as Keith mentioned, we were quite involved with PSI, is, you know, you give the guy or the gal the software and they say, I want to change it a degree. Fine. Change it a millimeter. Fine. IE, VV, and AP, proximal distal, and those are gross changes. You wouldn't malposition a tibial plateau fracture and be off by a millimeter, leaving the fractured part a millimeter depressed or raised, because you know it might have a consequence to the longevity of the knee. We're changing this all the time. And when you plan with software, it's too crude. When we put our metal guides or our disposable guides down on the bone and bolt them down, the planning of the operation and the execution of the operation are done in the same step. There's no image, there's no 3D model generation, there's no software to position it there. So just be aware that if you're using other techniques, check your cuts. And when you're off, if you over resect medially, let's say that you're supposed to cut 6 distal medial, then our guides have a millimeter, 2 millimeter shim to kick it out. And when you put the 4-in-1 referencing guide on, you kick it out 2 millimeters, pin it, and it'll cut the chamfers a little shallow. The implant will stick 2 millimeters per out and you fill with cement. So it's very easy to make corrections when you when you overcut distally. And if you undercut, so take another millimeter off. So we don't really have big issues. We're more accurate than a robot. We have 2 papers out on this now, and the learning curve is very quick. So that's why and I'll tell you what, if Keith and I did twins, we had twins and we operated on the same day, both varus knees, I'd call up Keith, what'd you do? Oh, I did 6 millimeter distal medial cut, 8 millimeter distal lateral, 7 posterior. He said to me, what'd I do? Exact same. So in different parts of the country, we could put the knee in the exact same spot, which cannot be done with MA, functional alignment, restricted kinematic. There's too many variables that the surgeon is adding in there. And this is a very simple recipe that then lets the implant now be fine-tuned, because my early experience with Vanguard for 900, Triathlon for 1,300, Diffuse Sigma for 500, a couple thousand personas, we couldn't move the bar in terms of forgotten joint scores with those implants because they were all pretty much the same. Low conforming medial lateral. They didn't have the stability medial and didn't allow the lateral side to move. So
I want to just bang through a couple more questions and then maybe come back to that last point. Over resection of the tibia was the question. Rarely happens. I think under resection, I will say the tendency for me is to not cut enough varus in a varus knee, and then having to recut it, and I almost always have to go up a size on the poly because of that. So getting used to it, getting better at it, not trying to get the thing in the middle of the ankle, you know, all the things that we've done for 20 years or however long you've been doing knees. Use the caliper, make the cut equal, and you won't have to recut as often, and you'll be thinner on the polys for sure.
Keith, one little point with that is when you don't tend to cut enough varus on the first cut, you run the risk of cutting a lot off the lateral side if you're not used to it. And that gets you the big poly. So my suggestion is when you have your guide up against your tibial guide, put the what do we call it? The stylus, and put that down. I prefer an 8-1, and I'll put it at the base of the lateral spine in a varus knee. So I know that my medial cut should be no more than 9 or 10, and I'm not going to get out of out of hand. And if I undercut, I'll use a recut guide, 2 degree, or if that's too much, I'll put an angel wing and put the 2 degree recut on top. Take 1.5 millimeters up to 3 off the medial side, and you're back in business.
Yeah, I think that all of those little tips have been instrumented very, very well with this design from this team. There was a question about any place for PS or PSC with this concept, and I would say not really. I mean, not that you can't do it, but you really don't need to. Like I said in my last case, and I've got, probably 100 knees now of bad varus that I would have backed up with a posterior stabilized, constrained PS plus, PS max, whatever you want to call it, primary constrained knee the last 20 years. I would have backed that case up and made sure they had it in the hall. And I do all of my cases at an ambulatory surgery center, so they would have to have it there with them for me to even feel comfortable going to the OR with a bad varus or a bad valgus. Knocking on wood, I haven't done a constrained knee with this technique since I started doing it, and that's out of several hundred, and where I would have done it at least a couple % of the time. So I don't think that it could you do it? Sure, but there's really no need to have to do it when it's done this way.
David Kingery has a question. David Kingery is a fishing buddy. David, I caught a nice rainbow today before this conference, just to let you know. He wanted to know, do I always set that tibia at 15 degrees or 15 millimeters at the ankle? And the answer is no. I just tend to start there to reduce the risk I'm going to under resect the varus. But once again, I think the key thing in the varus knee is to get the stylus at the base of the spine laterally where the cartilage is intact to conservatively cut the lateral tibia. Make sure you try to take an 8 or 9 wafer off with 1 millimeter. The kerf will get you 9 or 10, and then you can get the 10 spacer block in, and then you under resect and you can do the recut. So I really start it there, but when their visitors visiting me, I take a towel. I throw it over the extramedullary tibial guide, and I cover the ankle and I cover the bottom of the guide. And I said, do not look there anymore. Everything is at the joint line, and you train your eye to look at the joint line because your target is to restore that prearthritic, varus valgus inclination, and you'll get better at it. And then when you think you have it right, you measure the piece and you say, I was off a little bit. I really actually saw that and I should have changed it. And you do that for a while, measure, look, measure, confirm, you get better and better at it.
Here's I think a really interesting question. Marcos, I can't see where he's from here, but this to me is a super interesting question. So it says, the sphere was initially designed to resect the PCL. The unrestricted KA concept, we must preserve the PCL. Do the sphere insert you use have the posterior groove for PCL, or it doesn't matter? I'll answer that. I either take out the PCL or don't care 100% of the time. And by don't care, I mean, I take it out if it's too tight, like release the whole thing. And I use what is a posterior stabilized cruciate retaining design, or however Steve wants to call it. The more conforming of the conforming, with a cutout, maybe no cutout. I don't know the difference, other than I know the one I use, and I don't pay any attention to the PCL. I want the slope to look like Steve's phone, where it's equal medially and laterally and equal anteriorly and posteriorly, that I'm putting back the same material that I'm taking out.
Yeah, my approach is as Max said, I'm sort of a ligament guy, and it really hurts me to cut ligaments. And so the posterior cruciate ligament for me is an important reference because it's the way to keep the flexion space it's trapezoid, because when you cut it, it becomes more rectangular, and it keeps the balance. So early on, from 17 to 18, I did all with cutting the PCL because we didn't have an insert with a cutout. And I had a couple of knees where the flexion space would be a little loose for me, and I'd distract and push it back. I start to come up a little bit, and I said, well, I got to put a little thicker insert in. And then I do that, and I go to extension. It's not quite straight. And so then I'd say, do I need to take 2 more off the distal femur, which sometimes I would occasionally do. And if I didn't, I occasionally get a manipulation, and that's hard when you have a loss of flexion. KA, typically you lose flexion. you're at 100 degrees and you want 130. That's the typical thing. Extension usually is not the problem. And so for me, I prefer to keep the PCL because I don't have to worry about the flexion space laxity changing on me. And we do have some instruments that will help us. We have it's termed a goniometer, we won't talk about too much, but there's a way to set the rotation, let the soft tissues drive it for you to get the insert thickness just right. Because I also had some problems in the chubby leg and the heavy leg where I'd undersize the insert. I'm forcing it in. That's got to be it. And then Maybell comes back. This thing's a little sloppy, and oh, I should have put one in thicker. So we're trying to reduce all these risks. None of us are perfect. We do the best we can, but the more checks we can make that aren't cumbersome to the surgical technique and that are simple and easily and reproducibly able to do, the more likely you're going to have a home run. And then they'll send all their friends from the beauty parlor in to see you, and they'll send all their friends from their social circles in to see you, and you'll get better very fast and busy very fast. And I think you'll start to like doing total knees as much, if not more, than doing total hips.
I'm going to make one more. There was one question. Well, importantly, David wants to know if you caught that rainbow on a hopper. So I'll let you guys talk about that later. It was probably a hopper with a dropper, but that's fine. There's several questions about the patellofemoral joint. And this has been another one of the fascinating things about doing this operation is, as you look at it, everything we've learned, everything we've been taught, everything I've done for 20 years, these knees are uniformly internally rotated. And you would think that, oh my God, they're all going to maltrack. But the anterior cut is the grand piano sign every single time. And it's fascinating to me how that happens. And the patellofemoral tracking is outstanding every single time. It looks a little funny on the x-ray because the patella design is different than the domed type design that I've used historically. But tracking has been phenomenal. And the feeling of stiffness. I mean, how many patients do you get back that have 0 to 125 early, supple knee, maybe it's even a little unstable, and they say it feels tight. Tight band, it's in a vise, rubber band. It's like 30% of knees if you look at the study that we published with some other folks out of St. Louis. That really I won't say it goes away, but that is not the thing that people talk about anymore. And I think, I'll see what Steve's concept is, but I think we falsely want to externally, it's like on our boards, we want to externally rotate the femur in order to get the patella to look like it's tracking more normally. But that's not what it's doing. You're externally rotating the femur so that the distance between the trochlea and the lateral side of the knee may be shorter, but it changes your balance and flexion, right? And so then the actual tension on the kneecap joint is higher. And when you've fixed your arthrotomy laterally, or even if you've done a subvastus, the lateral side, or excuse me, medially, the medial side is now tighter than it was when you started the operation. You haven't put it back where it belongs. You've actually lengthened the distance from medial to kneecap, shortened the distance from lateral to kneecap, and in flexion made the patellofemoral force higher. And so you might have normal range of motion, but the knee feels tight because it is tight.
Yep.
And the magic of this is we look at the AP axis, Whiteside's line, oh my God, I'm internally rotated, the kneecap's going to fall out. But it doesn't as long as the rest of the knee has been aligned kinematically.
Yeah, that was a surprise to us too. One of the features of KA is not only does it restore, the normal distal femoral angle proximal to tibial angle, but it also restores the normal Q angle that the patient has had. Exactly. And when you look at 70% of the knees have constitutional varus and you're doing MA, you're increasing the Q angle in all of those patients. And so there must be a little offset, from the external rotation for the MA, and the Q angle sort of makes it a pretty good patellofemoral friendly situation. But with K, we've not seen this problem much. Now, not to say that there isn't room for some improvement, because I believe that in the next couple of years, we have some things going on now that it's for sure that if you can do a little bit more of that femoral trochlea, that you're going to, I think, move that forgotten joint score even more. And we got some pretty good evidence now on a 3-year study about that. So.
And the last thing I'll say, I won't even present this as a question because Max just popped up. That must mean we're running out of time. There were several questions, and we appreciate the questions. We might not have gotten to them. I think, Max, if you could give some folks maybe and someplace they can go to ask those questions, we can get them some answers. And there were several questions about revision. This webinar was not about revision. It looks like that might be a little bit of a hot topic. And I can say from my experience in the last little over a year, there's some pretty nice revision stuff that has this same logo on it. So maybe that is a topic for the future. But listen, Steve, this is super enjoyable. You know, I love chatting with you, and to do it with 100 other people that show this same passion that you and I have about this whole concept is super fun.
Great. And I just want to, again, thank you both for jumping on this evening. Really appreciate your time and your insight. I hope it was valuable to all the attendees on the call. Again, I will send a follow-up email to everyone that attended and all the registrations. So be on the lookout for that. If you have questions about anything you saw, or if some of the questions we weren't able to cover today, I do have a record log of what was logged down here, so I will be able to go back and filter through some of those, and we will do our best to cover those or present them to the surgeons for input a little bit later. So we really appreciate that, and we'll jump on that as well. Dr. Howell, did you want to say something?
Yes, I wanted to thank you, Max, for putting this together, and Keith, for the support that you've given. And I wanted to let you know, one of the things about MEDACTA when I joined them in 2017, I was looking for a home, and I found a home. And they have a slogan that says, "The surgeon is never alone." I think that's pretty powerful. The surgeon is never alone, meaning that they're for you. MEDACTA is there for you. So if you want to learn more, there's 3 ways that you can do that. Well, I'm going to give you 4, actually. One is you can take a course. There's a lot of cadaver courses that are run every 3 or 4 weeks in different parts of the country. You can pop in and do a couple cadavers. Visit somebody. I mean, I tell you, what I learned from visiting Keith was worth everything those 2 days. I even learned about how to improve my cocktail for the knee to reduce the discomfort post-op. So visit somebody. So we have the visitation. And then the other thing is we also have, go buy the textbook. Go buy the textbook that we wrote on it and watch the videos in there, and they'll sort of hopefully keep you out from making mistakes. And then the 4th one is you can actually have someone proctor you at your hospital. Someone can come in and MEDACTA will help you proctor someone there, bring someone that's learned to come in and help you do a case. So I think these 4 ways to learn are the future, and I hope you take advantage of them.
And you can find out more information on all of those things, including the reference centers and the learning centers, on our website, which will be provided in the email. So absolutely take a look at that. The training here is top notch, and it allows for a personalized approach as far as the cadaveric sessions. You get practically a one-on-one with the proctors and surgeons doing kinematic alignment. So please take a look. And again, thank you all so much for your time tonight. We really appreciate it here at MEDACTA. Dr. Barron, Dr. Howell, hats off to you. It was a wonderful presentation. We really appreciate your time. Thank you. And thank you, everyone else.